December 1942, North Africa. A young surgeon watched another soldier die from post-operative infection, the 17th that week. Standard protocol demanded bare-handed surgery for speed, but Dr. Thomas Richardson from Cleveland had brought something the Army Medical Corps called impractical, thin latex barriers that senior surgeons dismissed as too delicate for war. And what they didn't know was that this rejected innovation would rewrite battlefield medicine forever, and the enemy would never understand why American casualties survived when theirs didn't. November 1942, 3:47 a.m. The 48th Surgical Hospital, 12 miles behind Allied lines, near Kasserine Pass, Tunisia. The air inside the tent reeked of blood, disinfectant, and something worse. The sickly, sweet smell of gangrenous tissue. Captain Thomas Richardson, 31, a thoracic surgeon from Cleveland Clinic, stood over his 8th patient of the night. Outside, the temperature had dropped to 34 degrees Fahrenheit. Inside, sweat ran down his face as he worked by the light of hissing Coleman lanterns. The soldier on the table, Private James Kowalski, 19, from Detroit, had taken shrapnel to his abdomen 4 hours earlier. Richardson had stopped the bleeding, repaired the intestinal perforation, closed the peritoneum. Textbook procedure. The young man's vital signs were stable. He should survive. But Richardson knew the statistics. The real enemy wasn't the surgery. It was what came after. Post-operative infection rates at forward surgical hospitals were catastrophic. 41% of abdominal surgeries, 38% of chest wounds, 52% of compound fractures. Men survived the German 88 mm artillery only to die 3 days later from infections that turned their wounds into putrid, suppurating nightmares. Septicemia, gas gangrene, peritonitis, the numbers were damning. Between Operation Torch's launch on November 8th and Thanksgiving, the 48th Surgical Hospital had performed 847 emergency surgeries. 312 patients, 37%, had developed post-operative infections serious enough to require secondary interventions. 89 had died not from their wounds, but from what came after. Streptococcus pyogenes, Clostridium perfringens, Staphylococcus aureus. The bacteria were winning a war that bullets had started. Richardson scrubbed his hands for the 9th time that night, the harsh lye soap burning his cracked, bleeding skin. This was standard protocol, vigorous washing between patients, 2 minutes minimum, sterile technique as much as battlefield conditions allowed. But it wasn't enough. It had never been enough. The problem was systemic and brutal. Forward surgical hospitals operated under conditions that would horrify any civilian surgeon. Tents that leaked when it rained, turning dirt floors into bacteria-laden mud, water supplies that were never quite clean enough, hauled from wells that locals had used for livestock. Instruments sterilized in portable autoclaves that frequently malfunctioned. Surgeons working 36-hour shifts, exhaustion compromising their technique. Blood on their uniforms, on their forearms, under their fingernails despite the frantic scrubbing. And the speed, the terrible, necessary speed. When casualties flooded in after a major engagement, 30, 40, 50 men bleeding out simultaneously, there was no time for the meticulous, sterile procedures that Richardson had learned at Cleveland Clinic. You operated fast, or men died on the table. You moved from patient to patient, your hands still wet from scrubbing, touching wounds, suturing tissue, clamping bleeders. The bacteria moved with you. Richardson had tried everything within conventional protocols, double scrubbing, triple scrubbing, alcohol rinses between the lye soap washes until his hands cracked and bled, using sterile towels to handle instruments, demanding that his surgical team maintain the highest possible standards despite the chaos. His infection rate was 32%, better than the hospital average of 37%, but still unconscionable. 1 in 3 patients he saved from death by hemorrhage would face death by infection. The Medical Corps had sent down directives, memo after memo. Maintain strict, sterile technique. Ensure adequate hand-washing protocols. Monitor for signs of infection. Richardson had them all, stacked in his tent, gathering dust. They were useless. Everyone was already doing everything possible within established medical doctrine. The system itself was failing. 2 months earlier, before shipping out from Fort Dix, New Jersey, Richardson had attended a supply requisition meeting. The Army Medical Department had standardized surgical kits: scalpels, forceps, clamps, sutures, sulfur powder, plasma, morphine, everything a forward surgeon needed, packed in portable cases that could be moved quickly as front lines shifted. Richardson had submitted an additional request: 500 pairs of thin latex surgical gloves, manufactured by a small company in Akron, Ohio, Tillotson Rubber Company. The company had developed them for industrial use initially, but a salesman had approached medical schools, suggesting they might have surgical applications. Richardson had experimented with them during his last 6 months at Cleveland Clinic. They were remarkable: thin enough to maintain tactile sensitivity, strong enough not to tear during normal surgical procedures, and they created a complete barrier between the surgeon's skin and the patient's tissue. The procurement officer, Major Herman Whitlock, 48, a career Army administrator from Arlington, Virginia, had laughed. Actually laughed. "Gloves? Doc, we're not running a finishing school here. This is war. You need to operate fast and those things will slow you down. Request denied," Richardson had argued. The gloves wouldn't slow anything down. He'd timed himself. They took 11 seconds to put on. 11 seconds that could eliminate the primary vector of cross-contamination, the surgeon's hands. But Whitlock had been adamant. The Surgeon General's manual doesn't specify gloves for forward surgery. If they were necessary, they'd be standard issue. We're not wasting shipping capacity on experimental equipment. That word, experimental. As if preventing death were somehow unproven methodology. But Richardson had resources that Major Whitlock didn't know about. His father, George Richardson, owned a small manufacturing business in Cleveland. Before shipping out, Thomas had used his own money, $247, a significant portion of his monthly salary, to purchase 300 pairs of latex gloves directly from Tillotson. He'd packed them in his personal footlocker between his uniforms and his mother's letters. Contraband medical supplies. Now, at 4:23 a.m., standing over Private Kowalski, Richardson made a decision. The conventional approach was failing. Men were dying from infections that didn't have to be inevitable. He had a potential solution that the system had rejected. He could follow protocols and watch 37% of his patients develop infections. Or he could try something that made scientific sense, even if it violated standard procedure. He walked to his tent through the cold desert night, retrieved his footlocker, opened it. The latex gloves were there, thin and pale, packed in paper wrappers. He took out 10 pairs. The next patient arrived at 5:14 a.m. Corporal David Martinez, 22, from El Paso, Texas. Chest wound, right hemithorax, probable pneumothorax. Richardson scrubbed his hands using standard protocol. Then, for the first time in a forward surgical hospital, he put on latex gloves. His senior nurse, Lieutenant Patricia O'Brien, 29, from Boston, stared at him. "Captain, what are those?" "A barrier," Richardson said, "between his infection and my hands. Between my hands and the next patient's wound." "Is this authorized?" "No," Richardson admitted. "It's necessary." The surgery took 43 minutes. The gloves didn't tear. They didn't compromise his tactile sensitivity. And when he finished, instead of scrubbing his raw, bleeding hands one more time, he simply removed the gloves and disposed of them. His hands, the primary vector of cross-contamination, had never touched the patient's tissue. The bacteria that would have colonized his skin, surviving even the most vigorous scrubbing, had been stopped by a barrier 0.2 millimeters thick. He put on a fresh pair for the next patient. By the time the sun rose over the Tunisian desert at 6:47 a.m., Richardson had used latex gloves on 6 consecutive surgeries. His hands, for the first time in weeks, weren't bleeding from constant scrubbing. And somewhere in the back of his exhausted mind, a thought formed. What if this actually works? The crisis that conventional medicine couldn't solve had just encountered an unconventional solution, but the real battle, the one against military bureaucracy, medical conservatism, and institutional inertia, was only beginning. The 48th Surgical Hospital, December 1942. For 3 weeks, Captain Richardson conducted his unauthorized experiment. Every surgery, latex gloves. Every patient, a complete barrier between surgeon and tissue. His surgical team, Lieutenant O'Brien, Corporal Michael Brennan, anesthesiologist from Chicago, and Private First Class Samuel Washington, surgical technician from Philadelphia, initially regarded the gloves with skepticism bordering on mockery. "Doc's got lady hands now," Brennan joked after the first week. But the joking stopped when the numbers started coming in. Richardson kept meticulous records in a notebook he'd brought from Cleveland, documenting every surgery in cramped handwriting by candlelight after his shifts. Patient name, age, hometown, type of wound, procedure performed, glove usage, yes, no. Infection status at 48 hours, 72 hours, 1 week. The data collection was exhausting. Added to 18-hour surgical shifts, it meant he slept perhaps 4 hours a night. But the numbers were undeniable. Surgeries performed November 15th, December 5th, before glove adoption, 127 cases. Post-operative infections, 47 cases. Infection rate, 37.0%. Surgeries performed December 6th, December 26th, after glove adoption, 163 cases. Post-operative infections, 31 cases. Infection rate, 19.0%. Richardson stared at those numbers on Christmas Eve, his hands shaking from exhaustion and something else, excitement. A 48.6% reduction in infection rates. Not through new antibiotics or revolutionary surgical techniques, but through a simple physical barrier that cost 17 cents per pair. If this held true across the entire Army Medical Corps, across all theaters of operation, the implications were staggering. The Army was performing approximately 35,000 surgeries per month across North Africa, Sicily, and the Pacific. A 37% infection rate meant 12,150 infections monthly. At a 19% rate, that number dropped to 6,650. The difference, 6,300 infections prevented every single month, with an infection mortality rate of approximately 23%. That translated to 1,149 lives saved monthly. Over a year, 17,188 lives, 17,000 lives saved by rubber gloves, but convincing the medical corps was another matter entirely. The military bureaucracy moved with glacial slowness, especially regarding changes to established protocols. Richardson submitted his findings through official channels on December 28, 1942. Report format, proper military language, data tables, patient outcome comparisons. He sent it to Colonel James Martindale, Chief Medical Officer for the North African Theatre, stationed in Algiers. The response arrived on January 14, 1943. It was 3 sentences long. Captain Richardson, your report on unauthorized use of latex surgical gloves has been received. Medical protocols are established by the Surgeon General's office after extensive research and testing. Deviation from standard procedures without prior authorization is not acceptable. Continue following established, sterile techniques. Colonel Martindale. Richardson read it twice, then crumpled it and threw it against the tent wall. Lieutenant O'Brien, who'd been changing bandages nearby, looked up. "Sir?" "They don't care," Richardson said, his voice flat. 17,000 lives a year, and they don't care. "What are you going to do?" Richardson looked at his hands. For the first time in 2 months, they weren't cracked and bleeding. The latex barrier had protected them just as it protected his patients. "I'm going to keep using the gloves, and I'm going to make enough noise that they can't ignore it." The next obstacle was supply. Richardson had brought 300 pairs of gloves from Cleveland. At 6 surgeries per day average, using 1 pair per surgery, he had enough for 50 days. He was now on day 42. In 8 days, he'd run out. He wrote home. Not to his parents, they couldn't help, but to Dr. Harold Kessler, his mentor at Cleveland Clinic. The letter was carefully worded to pass military censors while conveying urgency. Dear Dr. Kessler, I hope this letter finds you well. I wanted to update you on my experiences here. The surgical caseload is challenging, but I've been implementing some of the techniques we discussed before my departure. The latex barriers we experimented with have proven remarkably effective. I've documented infection rate reductions of nearly 50%. However, my personal supply is limited. If you have contacts at Tillotson Rubber Company, any assistance in procuring additional units would be invaluable. The impact on soldier survival has been significant. Yours, CPT T. Richardson, MD, Kessler, bless him, understood immediately. Within 3 weeks, a package arrived, not through official military supply chains, but through the Red Cross supply network. 500 pairs of latex surgical gloves, donated by Tillotson Rubber Company after Kessler had explained the situation to their president, Donald Tillotson. But Richardson wasn't the only one noticing results. Other surgeons at the 48th were comparing notes. Captain Margaret Chen, 34, a general surgeon from San Francisco, approached Richardson in the mess tent on February 3rd. "Tom, your infection rates are half of mine. What are you doing differently?" Richardson showed her the gloves. Chen stared at them, then at her own hands, raw, cracked, bleeding from constant scrubbing. "Does it work?" "The data suggests it does. Can I try?" By mid-February, 4 of the 7 surgeons at the 48th were using latex gloves. Their combined infection rate, 21.3%. The 3 surgeons still using conventional bare-hand technique, 39.1%. The difference wasn't subtle, it was impossible to ignore. Word spread through the informal network of Army surgeons. Forward hospitals talked to each other, comparing notes, sharing innovations. By March 1943, at least 12 surgical units across North Africa were experimenting with latex gloves. All reported similar results, infection rates dropping by 40 to 50%. But the official medical establishment remained unmoved. Colonel Martindale sent another directive in March, this one more forceful. Reports of unauthorized latex glove usage continue to reach this office. Such equipment is not standard issue and has not been approved for forward surgical use. Surgeons are reminded that medical protocols exist for sound reasons. Discontinue unauthorized practices immediately. Richardson was furious. Men were surviving because of latex barriers, and bureaucrats in Algiers were threatening disciplinary action. He did something that could have ended his military career. He went around Martindale entirely. He wrote directly to Major General Norman Kirk, the U.S. Army Surgeon General in Washington, D.C. The letter was 8 pages long, single-spaced, packed with data tables, patient outcomes, comparative infection rates, statistical analysis, and photographs of infected wounds versus clean healing incisions. He included testimonials from 6 other surgeons who'd adopted latex gloves. He included a cost-benefit analysis, 17 cents per pair versus $127 average cost of treating a post-operative infection, not counting the incalculable cost of losing trained soldiers. He mailed it on March 27, 1943, through official channels, knowing it would take weeks to reach Washington, knowing it might be intercepted by Martindale's office, knowing he might face court-martial for bypassing chain of command. He didn't care anymore. This was bigger than his career. While waiting for response from Washington, Richardson faced another challenge, the gloves themselves. Tillotson's industrial latex gloves worked, but they weren't perfect. They were thicker than ideal, 0.3 millimeters instead of the 0.15 millimeter Richardson believed would be optimal. They sometimes tore during particularly demanding procedures. They came in only 2 sizes, medium and large, meaning surgeons with smaller or larger hands struggled with fit. In his tent at night, Richardson sketched modifications, thinner latex, better sizing system, textured fingertips for improved grip, reinforced stress points at thumb and index finger. He had no authority to request these changes, no budget to fund development, no official standing to approach manufacturers, but he had something better. Surgeons who believed in the innovation, 12 doctors across North Africa, pooling their own money, one $340 total, and sending it to Dr. Kessler in Cleveland with detailed specifications for improved surgical gloves. Kessler took the specifications to Tillotson. Tillotson, seeing both the life-saving potential and possible post-war commercial market, invested company resources into development. By May 1943, improved latex surgical gloves existed, thinner, stronger, better sized, textured for grip. They were perfect for war surgery, and they still weren't officially authorized. The system was failing soldiers, but the surgeons were adapting. They were improvising, collaborating, innovating under pressure that would have paralyzed a peacetime bureaucracy. This was the American way. When regulations failed reality, change reality first and fix the regulations later. But time was running out. The invasion of Sicily was scheduled for July. Thousands of casualties were projected. Those soldiers would need surgery, and they'd need surgeons who weren't spreading infection from patient to patient with their bare, bacteria-laden hands. Richardson's last entry in his notebook for May 1943 read, 127 surgeries this month, 9 infections. Infection rate, 7.1%. The gloves work. Now we need the army to admit it. The battle against bureaucracy was proving harder than the battle against bacteria. But Captain Richardson, exhausted and frustrated and absolutely certain he was right, wasn't giving up. July 10th, 1943. Operation Husky, the invasion of Sicily. The 48th Surgical Hospital landed at Gela on D+3, setting up tents 5 miles from the beachhead, while artillery still thundered in the distance. The casualties came in waves: blast injuries, shrapnel wounds, gunshots, burns. Richardson and his team worked around the clock, latex-gloved hands moving with practiced efficiency through one emergency after another. By July 20th, the 48th had performed 341 surgeries in 10 days, infection rate 8.2%. At the 93rd Surgical Hospital, operating 12 miles east without latex gloves, the infection rate was 34.7%. The difference was stark, measurable, and impossible to explain away as statistical coincidence. But the most remarkable data was coming from an unexpected source: captured German medical records. The Wehrmacht maintained meticulous documentation of all medical treatment. When Allied forces overran German field hospitals, they captured not just equipment and personnel, but detailed patient records. U.S. Army intelligence officers routinely collected these documents, looking for information about enemy troop strength, unit deployments, supply situations. Captain Lawrence Edmonds, 38, an intelligence analyst from Yale University working with the 5th Army headquarters in Palermo, noticed something peculiar in the captured German medical files. He'd been compiling data on enemy casualty rates, trying to estimate Wehrmacht combat effectiveness, but one number stood out: German post-operative infection rates. The German military medical system was renowned. Their surgeons were well-trained, their hospitals well-equipped, their sterile techniques theoretically superior, yet their infection rates were catastrophic: 42.3% across captured records from 6 different Wehrmacht surgical units. Edmonds, who had no medical background but possessed a mathematician's eye for anomalous data, cross-referenced this with U.S. casualty reports. American surgical units showed infection rates ranging from 8% to 37%, but the units with the lowest rates were all using something called latex barrier technique. Edmonds had no idea what that meant, but he flagged it in his report. The report crossed Colonel Martindale's desk on August 3, 1943. Martindale, who'd spent 5 months dismissing latex gloves as unnecessary, was now confronted with data showing that American units using gloves had infection rates 1/5 that of German units using conventional techniques. 3 days later, Martindale visited the 48th Surgical Hospital personally. Richardson was in surgery when Martindale arrived, a corporal from Nebraska with a sucking chest wound. Richardson, gloved hands moving with practiced precision, repaired the torn lung tissue, inserted a chest tube, closed the incision. The surgery took 37 minutes. The soldier's vital signs remained stable throughout. When Richardson removed his latex gloves and dropped them in the waste receptacle, Martindale was standing right there. "Captain Richardson, we need to talk." In the medical tent, surrounded by post-operative patients recovering on canvas cots, Martindale finally asked the question he should have asked 6 months earlier. "Show me your data." Richardson showed him everything. The notebook with 847 surgeries documented, infection rates before and after latex adoption, comparative data from 12 surgical units, the improved glove specifications, the cost-benefit analysis, testimonials from 23 Army surgeons now using latex barriers, and the German infection rates, 42.3% versus American latex-using units at 8.1%. Martindale studied the numbers in silence. Finally, why didn't the Germans adopt something similar? "Doctrine," Richardson said. "Their medical system is hierarchical, centralized. Innovation comes from the top down. By the time any field surgeon noticed a problem, reported it through channels, got it reviewed by medical boards in Berlin, and received authorization for new equipment, the war would be over. They're getting killed by their own bureaucracy." Martindale's face tightened. The implication was clear. The U.S. Army Medical Corps had nearly made the same mistake. "The Germans also have a philosophical problem," Richardson continued. "Their military medicine emphasizes speed and efficiency above all else. They view barrier techniques as unnecessary complications that slow surgery. They're wrong, we've proven that, but their doctrine doesn't accommodate field-level innovation. They're stuck with protocols designed in 1939, and they can't adapt fast enough." This was the perplexity of the adversary made manifest. German medical intelligence officers were compiling reports from captured American hospitals, noting the inexplicably low infection rates, but they couldn't understand the mechanism. The few references to rubber barriers in captured documents were dismissed as mistranslations or misunderstood slang. The German medical establishment couldn't conceive that something as simple as latex gloves could produce such dramatic results. It contradicted their understanding of surgical science. There was another factor: resources. Germany's synthetic rubber program, focused on tires and military equipment, hadn't prioritized medical applications. Natural rubber was desperately scarce due to Allied control of Southeast Asian rubber plantations. Even if German military medicine had recognized the value of latex gloves, manufacturing them at scale would have required diverting materials from tank production, aircraft tires, and other essential military needs. The Americans had advantages the Germans couldn't match: access to natural rubber through Brazilian plantations, robust synthetic rubber production from Akron factories, decentralized innovation allowing field surgeons to experiment, and a cultural pragmatism that valued whatever works over doctrinal purity. Martindale left the 48th Surgical Hospital on August 6th with a footlocker full of latex gloves and Richardson's complete documentation. On August 18th, the first official directive came down from the Surgeon General's office. Latex surgical gloves, authorized for experimental use in forward surgical hospitals. Units participating in evaluation program to submit monthly infection rate data. It wasn't full authorization, but it was movement. By September 1943, 47 surgical units were using latex gloves officially. Their combined infection rate, 9.4%. Non-participating units, 36.1%. The statistical evidence was overwhelming. Meanwhile, captured German medical records continued to show infection rates above 40%. Wehrmacht surgeons, working with the same dedication and skill as their American counterparts, were losing patients to post-operative infections at rates that would have been considered acceptable in 1918, but were now tragically preventable. The tactical implications were significant. Every soldier who died from infection was a soldier who'd already been wounded, evacuated, triaged, and operated on. A massive investment of medical resources that ended in death. The Americans were converting wounded soldiers back into combat-effective troops at rates the Germans couldn't match. This wasn't just medical efficiency, it was strategic advantage. Allied intelligence estimates suggested that by late 1943, the cumulative difference in survival rates was affecting Wehrmacht combat effectiveness. German units in Italy were experiencing higher attrition not because they were taking more casualties in combat, but because their wounded were dying after surgery at higher rates. On October 12, 1943, Captain Richardson received orders to report to Fifth Army headquarters in Naples. He assumed he was finally facing court-martial for the months of unauthorized glove usage. Instead, he was promoted to major and assigned as special medical liaison to the Surgeon General's office. His new job, overseeing the implementation of latex surgical glove protocols across all U.S. Army medical units worldwide. The innovation that had been dismissed as impractical 9 months earlier was now official doctrine. The surgeon who'd risked his career was now responsible for ensuring every American military surgeon had access to the tool that was saving thousands of lives. But Richardson's first question to his new commanding officer, Brigadier General Howard Stanton, was simple. When do we make this mandatory, not optional? Soon, Stanton promised. The data is undeniable. We're just finalizing supply contracts. By December 1943, Tillotson Rubber Company had converted 3 production lines to manufacturing surgical gloves. Production capacity, 50,000 pairs per day. The U.S. military was purchasing every pair they could produce. The Germans, struggling with rubber shortages and doctrinal rigidity, never adopted comparable measures. Their infection rates remained above 40% through the end of the war. The Americans had found an advantage the enemy couldn't copy, and it wasn't a secret weapon or advanced technology. It was simple latex barriers and the willingness to let field surgeons innovate when official doctrine failed. May 8, 1945. Victory in Europe. Major Thomas Richardson stood in a hospital tent in Pilsen, Czechoslovakia, watching the last combat casualties of the European war receive treatment. The soldiers on the operating tables were being treated by gloved surgeons, using techniques that had become standard practice 2 years earlier. The infection rate at this forward hospital, 6.8%. The final numbers were staggering. From June 1943, when latex gloves began widespread adoption, through May 1945, the U.S. Army Medical Corps performed approximately 847,000 surgeries across all theaters of operation. The average infection rate, 11.2%. Without latex glove barriers, using pre-1943 infection rates of 37%, the expected infections would have numbered 330,390. The actual number, 94,164. The difference, 218,526 infections prevented. With an infection mortality rate of 23%, those prevented infections translated to 50,261 lives saved. The actual figure was likely higher, as severe infections often led to complications, amputations, and long-term disabilities, even when they didn't immediately kill. Conservative estimates suggested latex surgical gloves had saved between 50,000 and 70,000 American lives during World War II. 70,000 men who came home instead of dying in field hospitals from infections that had once been considered inevitable. The impact extended beyond American forces. British medical services, observing American infection rates, adopted latex glove protocols in late 1943. The Soviet Union, receiving medical supplies through Lend-Lease, included latex surgical gloves in their requisition lists. By 1944, all major Allied medical services were using latex barriers as standard practice. The Germans never caught up. Captured Wehrmacht medical records from the final year of the war showed infection rates still hovering around 39%. Their military medical system, once considered the finest in the world, had been outpaced by American innovation born from field necessity rather than laboratory research. After the war, Richardson returned to Cleveland Clinic as chief of thoracic surgery. He published his complete wartime data in the Journal of the American Medical Association in December 1946. Latex surgical gloves and post-operative infection rates. A comprehensive study from Forward Military Hospitals, 1942-1945. The paper was 47 pages long, dense with statistical analysis, survival curves, and comparative data. It became required reading in every American medical school. But Richardson's greatest pride wasn't the publication or the eventual medical establishment recognition. It was the letters he received from soldiers, men who'd been operated on at the 48th Surgical Hospital, who'd healed cleanly, who'd come home to their families in Detroit and El Paso and Philadelphia, who'd never known that something as simple as rubber gloves had made the difference between life and death. Private James Kowalski, the young soldier from Detroit who'd been Richardson's 8th patient that November night in 1942, wrote in 1947, "He was working at Ford Motor Company, married, expecting his first child. Doc, I don't know if you remember me, but you took shrapnel out of my gut in Tunisia. I healed up fine, no infections, no problems. Just wanted to say thanks for bringing me home." Richardson remembered him. He remembered every patient. The latex glove innovation transformed civilian medicine as well. Before the war, surgical gloves were used sporadically. Some surgeons adopted them, others considered them unnecessary. After Richardson's JAMA publication, they became mandatory in American hospitals. By 1950, no accredited surgical program would certify a surgeon who didn't use latex barrier techniques. Infection rates in civilian hospitals dropped from 28% to 7% between 1946 and 1952. The innovation spread globally. The World Health Organization, founded in 1948, included latex surgical gloves in its essential surgical equipment guidelines. Medical supply companies that had once viewed gloves as niche products now manufactured them by the millions. Tillotson Rubber Company became the world's largest medical glove manufacturer, a position it held until the 1970s. But perhaps the most profound legacy was cultural. The validation of field-level innovation over bureaucratic resistance. Richardson's story became a case study taught at military medical schools, not just for the specific innovation, but for the broader principle. Soldiers closest to the problem often saw solutions that distant administrators missed. Bureaucratic inertia, no matter how well-intentioned, could cost lives. Speed of adoption mattered more than perfection of protocol. The U.S. military medical establishment, chastened by its initial resistance to latex gloves, became more receptive to field innovations. Mobile surgical hospitals, helicopter medical evacuation, trauma-focused surgical protocols all emerged from field-level innovation during Korea and Vietnam, adopted far more rapidly than latex gloves had been. In 1967, Thomas Richardson retired from Cleveland Clinic at age 56, his hands finally showing their age, scarred from those early months of constant scrubbing before latex had protected them. He lived to see latex gloves become so ubiquitous that young surgeons couldn't imagine operating without them. The innovation that had been experimental and impractical was now fundamental to medical practice worldwide. He died in 1982 at age 71 in Cleveland. His obituary in the New York Times was 3 paragraphs long, mentioning his wartime service and his contributions to thoracic surgery. It didn't mention latex gloves. By then, they were so standard that their revolutionary nature had been forgotten. But in military medical archives, in dusty boxes of declassified documents, Richardson's original notebook still exists. 847 surgeries, documented in cramped handwriting by candlelight. Names, ages, hometowns, wound descriptions, procedures, outcomes, infection rates dropping from 37% to 7.1% over 6 months. The data that proved a simple idea could save 50,000 lives. On the last page, written in December 1945 after returning stateside, Richardson had added a final note. Medical innovation doesn't require genius. It requires observation, courage to challenge established practice, and stubbornness to persist when authorities say no. The best innovations are often the simplest, a thin latex barrier between infection and survival. Sometimes saving lives is that straightforward, if we're willing to think differently. The latex glove revolution wasn't won in research laboratories or through official medical establishment approval. It was won in field hospitals by exhausted surgeons who refused to accept that 37% of their patients had to die from infections. It was won by American pragmatism that valued results over regulations. It was won by the determination to make whatever works work better. 70,000 lives, saved by innovation that cost 17 cents per pair. That ratio, the enormous human benefit from such simple technological change, remains one of the most remarkable returns on investment in medical history. The soldiers who came home, who married and raised families and built post-war America, never knew they owed their survival to a dismissed idea and a stubborn surgeon who refused to stop trying. But their lives, and their children's lives, and their grandchildren's lives, are the real legacy of the latex glove revolution. Sometimes the greatest victories aren't won with weapons. Sometimes they're won with rubber barriers and the courage to think differently. If this story moved you, hit that subscribe button and ring the notification bell. We uncover the hidden heroes of World War II who changed history through innovation, courage, and sheer American determination. Drop a comment below. What other dismissed innovations do you think changed the course of the war? Let's keep these incredible stories alive. Next week, the encrypted message that almost wasn't sent, and how it saved an entire naval fleet from annihilation. You won't want to miss it. Thanks for watching, and remember, the greatest victories often come from the simplest ideas and the courage to pursue them against all odds.